Well, thank you very much for that introduction. And it probably comes over quite clearly that I'm probably more of an expert in cats than dogs, but rest assured we're going to talk about dogs and cats this afternoon. So what I'd like to do in the first session is combine two things that are very related. First of all, how do we know they hurt? And then once we recognize that they hurt, how can we keep them comfortable? So we're going to combine that into the first session. And then in the second session, we're going to talk about how to keep them alive under anesthesia and during procedures. So some of the frequently asked questions I get commonly are, which analgesics are best? What about non-steroidals in cats? Single or multimodal techniques? And I'm certainly going to, on the pain management section, try and reassure you that pain management is still very simple, and very simple approaches can be very effective. How long do you need to treat? I think that's a very important question. Routes of administration, and then talk about some of the newer long-acting analgesics and if they have a place in our acute pain management. So this talk is really focused on acute pain management for surgery and trauma. I think we have to ask ourselves some key questions, and one of them I think we step back and ask is, can we effectively manage pain in our patients, in our dogs and cats? Well, I think the answer is absolutely yes, because we have lots of drugs and techniques at our disposal. So I think actually treating the pain is quite easy. I think the much harder question is that we have to actually recognize it. First of all, we have to look for it and then actually recognize that these animals are uncomfortable. So pain, we also need to think of it as a multidimensional experience. We've known for a long time, and it's very easy to understand the sensory part of pain, the ouch, it hurts, but where does it hurt and how much does it hurt? But I think we're all beginning to realize more and more that there's a very, very important affective or emotional component to pain. And I really like this quote from Jackie Reed, who I'm working with on some pain scale development. She says, it's not just how it feels, like ow, but how it makes you feel to be in pain. And I think there's no doubt that the emotional component of pain is very, very important in animals. So in humans, pain is what the patient says it is. Humans, even very young children, can self-report. They can say, it hurts here, it hurts this much, and then once you've conveyed that information, hopefully someone will help you to relieve that pain. We as veterinarians and people that look after non-verbal humans, so people that look after human neonates or people who have Alzheimer's, it's a very different thing altogether. For us working with animals, pain is what we say it is. It's whatever we decide it is, because animals cannot self-report. So there's a huge onus on us to get it right, because if we get it wrong, then obviously a lot of animals are going to be unnecessarily uncomfortable. The other thing we are beginning to realize, there's huge amount of genetic factors and individual variation involved in how animals experience pain and also in their response to treatment. So a lot of you have maybe been quite frustrated where you've got this anesthetic and analgesic protocol that works most of the time. And then there's an animal that just doesn't seem comfortable on this protocol. Well, I see that all the time. So don't be too upset about it. It's just that it means you have to look at every animal individually. And we are now learning from our research work, especially in cats, that some of the genetic factors on metabolism, response to opioids, and so on, are very, very diverse. And so don't be too worried if every now and again you get a cat or a dog that just doesn't respond to what is your kind of set protocol. So pain assessment, currently there is no gold standard for assessing pain in dogs and cats, and there are actually very, very few validated scales for dogs and cats. But we're going to go through some of the work that is being done, some of the very few validated scales, and then I'm actually going to show you things that I think are important to look at when you're trying to figure out if a dog or a cat is uncomfortable. So obviously, most of us are scientists at heart, so we always like to do everything objectively. What can we measure that says this animal's in pain? And obviously, a lot of the things that have been looked at are heart rate, respiratory rate, blood pressure, plasma cortisol, and even the size of the pupil. And some of these things can be used in combination with observing behavior. But none of these things in a clinical setting have been shown to correlate closely with pain. Certainly in a very, very controlled research environment, cats' blood pressure did seem to be a good indicator of pain, but then the minute that was used in a clinical setting, then it didn't have any correlation. So if you think about it, in cats and in dogs, things like heart rate are affected by, white coat syndrome and being in a hospital. Same with blood pressure. Pupil size, obviously, is of no use in cats. This cat, what do you think he's had? He's had an opioid, hasn't he? So no matter what he is feeling, he could be feeling pretty comfortable, but his pupil size is pretty much dictated by the drug that he's been given. So for a long time, people have just taken, scales and techniques that were used in humans that are very simple or used in lab animals and just tried to use those to assess pain in dogs and cats. So we have things like the simple descriptive scale. So you just say, go look at the animal and tell me if he's in no pain or if he's in the worst possible pain. And because we like numbers for statistics, you could just say, is it 0 pain or is it 5 out of 5? The other thing, which is maybe a little more sensitive, is to use visual analog scales. 0, no pain. 100 is the most pain you could observe. And then you just put a mark where you think this animal is on that scale. So the problem with these scales is we don't know whether a score of 4 is twice as painful as a score of 2. We don't really know that. But the biggest problem with just using something like that is everyone in this room has already probably been thinking about this cat. Everyone here is used to looking at animals that are painful or comfortable. All of you are working with cats on a daily basis. And if I asked everybody in this room who are experts to score this cat just from this quick visual, I can guarantee we would have at least a 30 to 40% divergence in everyone's opinion. So it depends on what you've been taught, what you know to look for, and so on. So the problem with these scales is they're very, very inaccurate for different people to use. If the exact same person does it over and over, then they could be useful. So pain scoring system, we have to have clearly defined assessment criteria. What should you be looking for, and why should you be looking at that? And so really all pain scoring systems for dogs and cats are based very, very heavily on understanding behavior. They need to be suitable for all observers. So in a very busy clinical situation, they need to be suitable for all the staff, the veterinarians, and for, in my case, students to use. They need to be simple and quick. Otherwise, they're never going to get used. They need to be sensitive, pick up animals that need intervention. They should have identified strengths and weaknesses. If the scale is good for picking up post-spay pain, is it going to pick up orthopedic pain? And then the most important thing is the scale needs to be validated. Is it measuring what we think it's measuring, or is it really only measuring the effects of anesthesia in the recovery period? That's a very important concept. So let's just look at this dog. This is Ty, 15 years old, ate a tennis ball and needed a GI resection anastomosis, and this is him 2 days post-op. So I just want to show an example of what can happen if you use the wrong pain scale. So everybody kind of looked at him and probably had a gut feeling, no pun intended, about how he feels. But if we used this one scale that was published way back in 96, which was never really validated, but someone just said, this is what dogs do when they're painful. And so if we scored Ty, what was he moving? No, so he gets a 0. Was he agitated? No, he was pretty calm, standing there. He wasn't vocalizing when we looked at him, 0. I think we all kind of felt that he was uncomfortable, but basically on this scale, he's a 2 out of 8, so he doesn't hurt. Was that everybody's opinion? No. So this is what can happen if you don't use good validated pain scales. So sometimes a snapshot doesn't give you the whole story, and we have to do a little more than just look. We have to interact and do many other things and find ourselves the correct pain scoring system. The other thing is a pain scoring system should guide intervention. This is something that just irritates me a lot. To walk into the clinic and see that stuck on a cage. This cat's painful, this dog's painful, it will bite. And I'm like, well, if we know it's painful, why have we not done something? The other thing is that they should guide your intervention, but not necessarily dictate it. Because you may find that you get a very nice pain scale that works for you. You go through the system, and the dog or the cat scores a low score, but you know that cat or dog could look better. So it shouldn't inhibit you intervening and then reassessing the animal later. So they definitely should guide, but not dictate intervention. So pain scoring system, it should account for the species. Obviously, a scoring system for the dog is not going to work for the cat. Kind of very different behaviors in those two different species. Sometimes I really feel like we have to account for breed. Do people think Labradors and Huskies act differently in the post-op period? Yes. So there's a big issue there with even with breed. And then the type of pain. Where's the pain? Is it orthopedic pain? Is it abdominal pain? And how long have they been painful? Is it acute pain, or is this a chronic pain syndrome that we're looking at? And then obviously environmental issues. How an animal behaves at home is going to be different from the hospital. And that's where it's very important sometimes to engage the owner, if the animal has an owner, about the animal's normal behavior at home and whether or not that has changed in the hospital. The other thing I'm finding with developing a pain scoring system for cats is that sometimes you kind of look at a cat and you go, is it pain, stress, or fear? And certainly the group I'm working with at Glasgow, we've discussed this at length. And what we've decided is that it's quite difficult, or it can be difficult, to differentiate pain, stress, and fear in cats. But we've come to the conclusion that all of these are aversive. So in theory, all of these things ought to be addressed in a cat in a clinical setting anyway. But for example, we're going to go through some things that I think are important. For example, where the head is, and body posture, and facial expression. And this cat on the left has not had surgery, and the cat on the right has had surgery. And for some untrained observers, they have difficulty differentiating between these two cats. Now, I know exactly what's happened to each cat. I have a good feel for what to really look for. But some of the postures that fearful cats adopt are the same postures that painful cats adopt. So what do cats and dogs do when they're painful? That's the big question. And so what I want to go through is some of the work that is being done, and then go through what I think is important, and then try. I think you can only really get a feel for this by looking at a lot of pictures and at a lot of videos. So what we're going to do is, first of all, talk about some of the work that's been done by the group in Brazil. And so the Brandani group, what they have done is they've taken information from lots of previous studies, looked at what people have assessed pain with in cats, and then actually tried to validate this their pain scoring system for cats. And currently, they've only looked at it following ovariohysterectomy in the cat. So this was published this year. It's a very, very good paper. It has a lot of good information in it. It goes over the importance of looking at posture, comfort, activity level, mental status, which certainly I think is important, but a lot of other people kind of say, well, you can't say that animals are happy or bored or so on. But I think everyone in this room, we can say that, because we can. Blood pressure, they have looked at that as an adjunct, not as a substitute for looking at behaviors. Reaction to wound palpation is important post-surgically or post-trauma, not always possible. Things like appetite, vocalization, and then they have a list of miscellaneous behaviors which are pretty interesting and very similar to what myself and the group at Glasgow have been looking at. For dogs, probably the only validated, or certainly I think it's the best validated, pain score that we have for the dog is the short form of the Glasgow Composite Pain Scale. It just happens to be where I graduated from, but to be honest, it really is one of the best scales. And there is a complete copy of this in your handout, and you can go and download it at the Glasgow University website. You just have to sign on and sign a little waiver because it is a copyrighted document. But you can easily download it at their website, and there's instructions in your handout how to get this. And again, somewhat similar to the cat scale, they look at demeanor and response to people, posture, mobility, activity. They also think that response to touch, and certainly the wound is very important, what the animal is doing to the wound itself, and then for the dog, vocalization, they think is an important thing to assess and interpret correctly. So this form is a very simple one-page form that took 2 PhDs, 1 master's student, and 5 years to develop because it is so well validated. They started out asking veterinarians for words and descriptions of pain in dogs. There was 247 words that came in. Some of them were very, very Scottish, and they had to be taken out. Like, I'm guessing that none of you would know what a scunnered dog looks like. So for the international release of this, that was taken out and turned into a word that everybody understands, and so on. And then what they did was they ended up putting the behaviors into 7, and now currently on the short form, 6 specific behavioral domains. So that is how much is involved in developing a good validated pain scale. Now we are currently, and I'm involved in this project, trying to develop a very similar one following the same route as the dog one for cats. So we are developing the GLASGOW composite measures pain scale for acute pain in cats, and we've gone through having people send us in words. We did an online survey where people were asked to differentiate between words and how they related to pain in cats. It is currently under construction. I don't know when soon is, but we are working on this, and hopefully we'll have something in the next year. So I think it's important to say, what are we looking at and why are we looking at that? So I'm going to go through postures, behaviors, and when I say behaviors, presence or absence of normal behaviors, but also looking for new or abnormal behaviors to develop after a surgical procedure or after trauma. We're going to look at what vocalization might mean, and then palpation of the wound, overall demeanor, interaction with a caregiver, and then I'm going to talk about some of the work we're doing on facial expression in cats, and then some of the miscellaneous behaviors, which people always say, well, what about this? And one of them I'll talk about is, what does the cat's tail tell you? And we'll show some videos of that. So look for normal behaviors. And so once you know cats and dogs, and you know what normal behaviors are, you should be looking for animals in a hospital after a surgical procedure or after trauma to exhibit normal behaviors. So what was that? It was the normal cat stretch, right? That is a behavior that you should see that in post-surgical patients if they're comfortable. Looking for this. So look at this cat before and after. So you can see this cat had a flank spay, and the behavior before and after surgery was their normal behavior. He was up at the front of the cage, he wanted to play, he was interactive, bright and alert. So you want to look at the maintenance of normal behaviors. That's a good sign. If they look the same before and after, then your pain management protocol is good. One of the things that I have started looking at carefully in the dog is like normal dog behaviors and how they might be altered by pain. So all of you, when you see your dog get up, and when you see these videos, you'll say, I've seen that. So what did most dogs do when they get up? They get up, they usually stretch, it seems for some reason, most often they stretch twice, and then they shake themselves. And a lot of dogs, that's a very normal routine. Now, you know that, but then if you start looking at surgical dogs or dogs post-surgical, you can often see that dog shake be very, very altered. So what you'll see in animals that are painful is that the shake is what I call pulled when it reaches the painful part of the body. So I'm going to show a video of a Springer Spaniel. And what you'll see is that he'll shake ahead of and caudal to his painful incision. He's had a thoracotomy, midline thoracotomy, and an abdominal surgery. So one of the things that we look for is to intervene and then look at the return of a normal dog behavior, a very basic dog behavior, the shake. So what I'm going to show you is, and watch carefully, so this dog, when we show the first video, has a shake that is pulled ahead of and only is initiated caudal to his painful body part. So here he is. Do you see that? He shakes in front of his incision, and he shakes just a little bit behind his incision. But he doesn't do what you all recognize as the real dog shake. So obviously, and for all other things, palpating his wound, there were lots of other things. So there was major intervention to improve his pain level. And now look at him afterwards. And then you see and recognize this normal dog behavior. So he's much, much better. But wait till you see him do his real shake. Yeah. So does that suddenly put on a light bulb? Like, oh, I've seen that. But that dogs will do that. They won't shake at the painful incision. So look for things like the real dog shake, good sign. The dog stretch. Now, we said when dogs get up, they usually stretch. This is a dog stretch. This is not a good dog stretch. This is a dog that is actually quite painful. You can see she's had a spay here, a spay incision here, and that actually, she's just waking up from anesthesia. But if we went then and palpated her wound, we would probably find that she was tense and so on. So that stretch is not a waking up stretch. She's coming around from anesthesia, and that's actually a painful dog stretch. Orientation in the cage is important, but obviously, certainly with cats and with dogs, depending on their personality, there's some of them that always want to be up front, and some of them that are scared and shy and want to be at the back. So on a single observation, orientation in the cage is probably not very useful, but it is probably very useful for a specific animal. So here's a cat comparing it before and after surgery. So before surgery, he's up front and actually can unlatch the gate. And here he is after, had major orthopedic surgery, but where is he? He's up front trying to get out. Good sign he's at the front of the cage, the way he was earlier, interested in what's going on. Now, comparing over time, here's a cat that was in our ICU unit a few weeks ago, was doing well up at the front, and then as his pain management lapsed and he wasn't doing so well, he went to the back of the cage and was trying to hide. So that gave me an indicator that something wasn't right with him. And again, with dogs, up at the front, interested in what's going on, or, at the back here, just please don't bother me and please go away, not interested. Probably good things to even just briefly, inventory, like where is that dog sitting and what's his interest in what's going on. We're going to look at posture in cats and then in dogs as well. And so again, once you know what normal postures are, you can start to pick up the abnormal postures. So on the left here, we have one of my cats in a normal 18-hour-a-day posture. So, very relaxed, curled up, very comfortable. Here's another cat sitting in the clinic. Actually, if you were there, you could tell that he was really quite relaxed. His head is up, his eyes are looking at you. You might all go, he looks a little nervous, and I would agree. But these are fairly normal postures. And then we'll talk about, he's got his little front legs turned in there, in the pretzel pose, as I call it. So these are fairly normal postures. So then you start looking for abnormal postures or normal postures in a hospitalized cat. So here we have the normal, healthy, non-painful cat. Now here's a cat in a very similar position. And this to me is a good sign. I go to check the cat, and the first thing I see is a nice, relaxed posture. This cat actually has a feeding tube in, a fractured jaw, he's got in IV lines, but he's adopted a normal posture. Good sign. Now here's, again, comparing normal and abnormal. So this cat, this is not a normal posture. And you'll start to pick up that there's something about his face as well that makes us wonder how comfortable he is. This is a post-amputation cat. He's fairly flat out, and if you were there in reality, he's actually quite tense, and then he has this facial expression. So abnormal posture, we need to look at that cat quite closely. So tucked up and crouched after abdominal surgery is something that is documented. And if you videotape cats before and after surgery, them getting hunched and tucked up is a behavior that emerges after surgery, which is rarely exhibited prior to surgery. And certainly Dr. Warren, she published on that. We've got some preliminary data from the group at GLASGOW. So this hunched up or this hunched posture is classic for abdominal pain in cats. You'll also see the head is down, And there is this facial expression, the eyes, and we'll talk about what that might mean. But a lot of you are going to say, well, sure, but that's what fearful and scared cats do. They go to the back of the cage and they crouch. Well, I would agree that that is true, but when you start looking really carefully and looking at before and after, I would say that yes, fearful and scared cats go and crouch at the back of the cage. But look at this specific cat before and after. So yeah, there she is, scared and hunched up, but look at her after surgery. Look at the difference in her face and her eyes, and then look at that body posture. So when you start looking at the difference before and after, that's when it really looks very obvious. And this is why usually you have your technicians are the ones that are key to telling you what's going on with animals in your clinic or at the hospital, because they see them before and they see them after, and we're often in the surgery room and we're missing this type of thing. So posture in dogs, again, the head up, alert, looking out, versus the flat out, obviously exhausted, I'm painful posture. So certainly you get used to looking at these normal postures. And again, these are two classic bad postures that we wouldn't want to see in a dog. Head down, kind of like trying to relieve the pain in the abdomen. And again, here's a dog, head down, and trying, obviously, somehow to relieve its abdominal pain. Here's a dog 6 hours post-ovarian hysterectomy. And as soon as we go to the cage, we know something's wrong. I think there's something wrong. She didn't want to get up, but she was at the front of the cage. We got her up, we get her out, and we see that posture. The praying posture is something that's well described in the literature. We don't see it very often now that we have good pain management protocols in place, but you will see it every now and again. And this is a classic sign of severe abdominal pain in a dog. You'll see it after spays, splenectomies, any kind of abdominal procedure. And she's actually, when they were assessing her pain, very, very tense and flinching to palpation of the wound. So obviously, you don't need a complicated pain scale to say you need to intervene and do something. And then we did, and here she is following intervention. So she's already up because she heard us coming. She's at the front of the cage. We get her out. We're palpating the wound, and she's relaxed, completely different dog, and we watched her for a while, and she didn't adopt that prey posture. So we should not be seeing that prey posture. Do not confuse it with the dog stretch when they first get up. It's a very different behavior when you look at it carefully. It's not a normal dog stretch. They look like they're praying. What about vocalization, and what does it mean? And certainly in the GLASGOW composite pain scale, vocalization is one of the behaviors that is in one of their 6 categories they look at. With cats, I think it's maybe not as clear cut what vocalization may really mean. But listen to this one. So probably everyone agrees, not a happy sounding cat. Yep. So he's had major orthopedic surgery, but there's some other things. That's that little cat that you saw who usually was at the front of the cage wanting to get out. Where is he now? He's at the back of the cage. Did anyone notice what he was doing with his lips? Licking. See that quite a lot in cats that are painful. Now, they'll do it when they're nervous as well, but you'll see it a lot in pain cats. And then the other thing he was doing was extending his back legs, and that, again, is a pain behavior in cats, and that's been documented by the group in Brazil. So he has a lot of things going on that make me think he is not happy. What we were focusing on there was his vocalization. So we intervened, and then he sounds a little bit different later. And again, all these things we're building on. Look at the next video. Where is he in the cage? What's his interaction with me compared to his interaction in this one? Yeah. So it sounds very different. He was at the front of the cage, and so it sounded like, oh, don't put me in the cage again. So a very different before and after picture there. What about this? Okay, so something that we see just as animals are waking up. and it can be quite difficult. Is that pain, or is it what we call emergence delirium? They're waking up suddenly after surgery, and that can be a very difficult thing to figure out whether they're painful or delirious or emerging from anesthesia. We're going to look at another video, which is like, is this dog dysphoric or is he painful when you're just looking at him? So sometimes when you look at them, it can be, is it emergence delirium, is it dysphoria, what is it? So obviously you have to go in and figure out, is it pain or is it dysphoria? What you sometimes see, you see quite a lot of dysphoria sometimes when animals have had too many opioids. We've been very proactive in like giving more and more analgesics to animals, and sometimes you'll see a dysphoric animal. Now, if he had been a husky and behaving like that, would everyone have just dismissed it? Most people would have said, it's because it's just a husky, right? So you've got to be very, very careful that you're not being, breed, sensitive and so on. So this dog, we then went in, palpated his wound, reassessed him, and so on. Now, what I find is if an animal is painful, usually when you palpate the wound, you're going to get a reaction. The other thing is usually you can distract a painful animal for a short period of time. You can get its attention and get it to calm down just for a second. If they're dysphoric, they are out to lunch and they are not going to calm down. You can try and hold them, you can try and calm them down, and you can't. So sometimes that's a good way to differentiate pain and dysphoria. So then the question is, what are you going to do? And sometimes you're not sure. Sometimes, to me, it's very clear that the dog has had way too many opioids and is dysphoric. And so what I will sometimes do is get a very, very dilute solution of naloxone and start very, 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 very slowly titrating a little bit of naloxone into them, and then suddenly you'll get a dog that's behaving normally. If you've used an opioid agonist like morphine or hydromorphone, you could give some butorphanol and see if that brings them back to normal. But sometimes you're like, oh, but what if I'm wrong? I'm going to make them more painful. So what we did with this dog, I was pretty sure he'd had too many opioids, but not everybody agreed with me. So I went with the consensus opinion was that maybe he was still painful, but we could maybe sedate him and not reverse him. So what did we do? We gave him dexmedetomidine. Good analgesic, good sedative if you're just not sure. And now we have, obviously, someone checking the heart rate to make sure it's okay. But we have a relaxed, calm Labrador who, obviously has now more pain medication on board. And then we can, what I decided was not to give him any more opioids, let him wake up and reassess him later. But the pain, dysphoria, and emergence delirium can be difficult to differentiate. Wound tenderness, I think, is something that is very important to look at if you can. And certainly we've done studies, and studies have been published where we've used specific pulpometers that measure how much pain or how much pressure we can apply to a wound before the animal responds, and look at different anesthetic protocols and so on. So I do try and do this as much as possible with dogs and with cats. So let's go through just a couple of wound assessment things. You can see the hands creeping in. And you can hear, it's Dr. McCune in the background saying, I'm not touching her anymore. I think we already know. And she's right. So, but did you see where's the cat in the cage? And we knew this cat. This was a cat that belonged to someone that works at UF. So we knew it was usually a friendly cat. What about this facial expression? We're going to go into that in more detail. And did you see her licking her lips as well? And barely palpating this cat. This was a mastectomy case. Barely palpating her, and obviously very obvious response. And we intervened and made her much better. What about this one? You've seen this cat before. He's the friendly, wants to get out cat. Yeah, so he had had a bone graft taken out of his shoulder. The resident's pressing pretty darn hard, and he's like, well, you can obviously tell he's on opioids, right? But, no response to palpation, so excellent. And then there's the in-between. And now, I'm guessing everybody in this audience is going to get this one, but a lot of people who are not good with cats won't get this one. So this is Bob, who has a similar injury. He's got he's had his graft taken there. So I'm guessing everyone here knows that was a normal cat greeting behavior to me. That was not a response to palpation. But a lot of people that don't speak cat would say, ooh, I poked and he lifted his head up and did that. He responded to palpation. So again, the better trained your staff are at normal interactions with animals and knowing what that is, the better. Because that was like, of course, and then we went back and we palpated his other wounds and he didn't respond and it was good. So understanding normal behavior, very important. Now, not always possible. Yeah. So that cat, I'm like, okay, I am not going to be palpating your wound. And obviously, when we work with feral cats, that is going to be the biggest issue. So it's not always possible, but certainly if they're showing all these other behaviors, you're going to intervene and hopefully have a much happier animal. Here's a dog, post-spay. So you could tell I wasn't expecting that when I went up to her. So I had barely even started palpator, so she's very hyperesthetic and very painful there. And then after she sat up, she didn't bite me, she didn't, she's waking. But did you also see what she was doing? Lipping. That is another well-defined, documented pain behavior after ovarian hysterectomy in dogs. So the licking the lips is another component of that video. So obviously, intervention's required, and we go back, and I'm being a little more careful this time. And then I see she's much more relaxed, not as tense. So there's some response, and she's going to, as I apply a little bit more pressure, there's a little bit of response. So she's not perfect, but she's certainly much, much improved from the first video. Facial expression, I think, can tell us quite a lot. And it's not just, there's some science to looking at the facial expression of animals. And we'll go through a little bit of that. And I got very interested thinking, well, people that work with newborn babies, kind of a similar responsibility to us. They have to get it right, but these babies can't talk. So this is some work that was done actually in a hospital in Orlando. And they've been looking at what they call the primal face of pain in babies. So this is like every baby in Florida has to have a blood test when it's born to test for some specific genetic defects. And so what they did was they put a video camera above the baby's crib and started filming before, during, and after pricking their heel to get that little sample. So a very acute, noxious stimulus. And what they were able to find was they could actually get these specific markers on the baby's face and actually document with computer analysis what changes with acute stimulus. And so obviously this furrow gets bigger, the eyelids change, and all these things that a mother would obviously instantly recognize, but this can all be scientifically downloaded and looked at and can be used as a measure of pain in babies. The mouse pain face has also been looked at. This was published last year in the lab animal literature. And actually what they did was they had mice with abdominal pain and videotaped their face, and what they were able to start to pick up on was a cheek bulge, whiskers pulled back, and then this cheek bulge, whisker, and their head position. So there's no doubt that mice with abdominal pain have a facial expression that is very recognizable if you are used to looking at mouse faces. Now here's another one, again, looking at adults and trying to develop techniques for understanding pain in Alzheimer's patients. What does that facial expression really mean if they can't communicate? So these are people that are being videoed. You can do all this very complicated, map out their facial action units, and so on. Now, we've started actually looking at this type of technology and trying to develop it and look at what do cats do with acute noxious stimulus. So the next video I've got, I want you just to focus on the cat's faces. And this is me looking at the cat's face, and this is just a few of the ones I've collected as our students are trying to place an IV catheter. So just watch his face. Get it? See it? See it? Obviously the catheter didn't go in. So we're trying again. Oh, we're trying again. And then the next cat, you'll have to watch really quickly as the catheter gets in. Look, did you see it? What he did? So there's no doubt that there's facial action units in cats in response to an acute stimulus, and we're going to try and document that. So, facial expressions in cats. Yeah, it's a good one. So, I began to think there was something in it, you know, because this is the pain scale that they show very young children. Please point to how you feel. So here, that's that cat, and that's this cat. So there's a little, it's a little bit better documented than that, but there is something to it. So I have started looking at this, and here's a normal cat, head up, eyes are fairly horizontal in the head. Here's a cat that you've actually seen this cat already in the presentation, but we've just focused on its head now. Look at the position. His eyes are half closed, they're slanted, different altogether. And actually there's some, the whiskers are pulled back compared to this relaxed cat. So here's others. You start looking at these things again, before and after. This is Max, who had a degloving wound. Here he is when his pain management's really good. Here he is when things are not so good. And I've got some more pictures of Max. Look at that. Look at the difference between that and that. Big difference, right? So I think the face probably does tell us quite a bit. And, you know, some people say, well, you know, a lot of the drugs that you give for anesthesia will make a cat's facial expression change. And I went, again, it's a bit like a scared cat's going to get all hunched up. True, but it's different when they're painful. So here's a little cat called Nimbus who was going to have dental extractions done. Here he is before in that sort of like pretzel, kind of crouched. And so here's his face before we did anything to him. Then we sedated him with an opioid and ACE. And yes, I agree, his face has changed. But this is him after he's had his dental extractions. And I think you'll agree that it is different. And if you want to see it sort of for real before, during, and after, this is what the difference comes out as. So up at the front of the cage, friendly cat. He's like, oh, okay, you can stroke me. Then we sedate him, and there's a definite change in his expression, but he's still quite relaxed, got his little front paws, the pretzel position, looking at us. And then 3 hours after his procedure is over. Where is he in the cage? He's at the back, yes. And he's breathing heavily. And some people might have an opinion on his tail. So very different. Facial expression can tell you quite a lot. So one of the things that came up in the Brazilian study is, what does the cat's tail tell you? I would say right now we're not sure, but I've got some videos of what cats' tails do after surgery. So this is little Max, the one with the degloving wound. And so we're starting to try and figure out, what does it really mean? We're not sure. It's a bit like vocalization. It's not as clear-cut in the cat. But you obviously, you know, and here's another cat after orthopedic surgery, you know. And, you know, some cats do this just when they're annoyed, but could it be a pain behavior? And this needs, I think, a lot more before we start actually assigning flicking of the tail as a classic, you know, pain behavior in a cat. So just to try and make you start looking at cats and dogs, just to even start looking for pain, we came up with these very straightforward, like 4 pictures that people should start looking at. And so this is the one. This is the normal, happy cat, you know, eyes horizontal, open. You know, we call it the croissant, but that was kind of for the French market. So maybe for us it could be the bagel, and then we could have the pretzel for the Germans. And then we've got what got called the humpy, and this is the cat that's all crouched up after abdominal surgery. And then we have the squinty, which is the cat with the slanted eyes, and I'll look at the different, we did a diagram of that, and then we have the flat out, not a normal posture. And sometimes just putting these pictures up makes people start looking for these and starting to say, oh, I need to look at that cat a little bit better. And then there is this scale that you can download at the CSU website, and there's information, and it's actually in your handout as well. It's not validated, but it has a lot of the things we've been talking about here, and it's a 0 to 4 scale, and has some good descriptors. And this, I think, can be used and can be quite useful as well. And then, if you're going to start introducing a pain scoring system, probably the dog one I would definitely recommend would be the GLASGOW short form, which is it, again, in your handout. So now that we have better skills and better tools, let's look at that first dog just one more time. The dog that only scored a 2 out of 8, but everyone was going, he's not a 2 out of 8. So here he is again. So he's standing there. We've got an idea of his face. He's down. We're going to come in and try and get him to get up. Or at the moment, he's being asked to get up. He won't get up. He needs help to get up. The audio is not going at the time, but he is actually making not good vocalization. And then we just slipped in and tried to palpate him. Very, very tense. And then he did respond to us palpating his wound. So you all knew that that was a painful dog, but the pain scale didn't say it was a painful dog. If you take the GLASGOW pain scale and now look at him, he was quiet, so on that domain, on the first one, he doesn't get a score. And he was, at the time, ignoring the wound, but he refused to move, so he got a 4. When we started palpating him, he was actually starting to growl and started to cry, so he gets, even if we took that out, he's going to get a high pain score. Everyone obviously agrees he's depressed and doesn't respond to us trying to get him to get up, so he gets a 4, and when we palpated, he's very rigid, he gets a 3. So out of a total of 24, he gets a high score. So when you do the appropriate scale, then obviously this is a dog, and the GLASGOW pain score, the recommendation is a dog that scores over 7 needs intervention. And so obviously this dog needed additional treatment. And if we go back to this little dog, I think this, in your handout, you'll see part B, 3 of the GLASGOW pain score is very important, I think. Dogs getting up. Will it get up, or does it refuse to get up? So the dog we already saw, and then that's the spaniel that lost his real dog shake when he was very painful, didn't get up. So this assessing how they get up when you first go to the kennel, I think is a very important part of that GLASGOW pain scale. So putting things a little bit together, trying to put all of those things. Here we're going to look at a cat, which gives us a few mixed signals. And we're going to see what you guys pick up on. So this is Levi, who had a horrible injury to his leg. They tried to save it for many weeks, maybe months. And then finally, the only solution to his problem was to amputate his hind leg. So, and there should be good audio on this. So just listen and watch carefully what Levi does after his amputation. He's going to mark his cage and then fall over.
Yeah, good boy? What's going on? Oh.
So again, if you aren't really in tune with cat behavior and stuff, his vocalization doesn't sound good. Did everyone figure out what he's vocalizing in response to? The dogs. Yeah. So lots of people don't, so you guys are obviously in the advanced group. A lot of people look at that and say, man, that cat just is growling away. And I go, I didn't really, if I thought he was really growling and going to go for me, I wouldn't have been in there petting him and doing all the other stuff. So he did lots of normal behaviors. He was eating, He was starting to groom, he was exploring, but the one thing that was a bit of an outlier was his vocalization, but you figured it out. It was because there's dogs barking, and, you know, he's going to tell you that's not, you know, the dog should shut up. So here's a cat, 4 hours post-amputation. And, you know, people might say, well, you know, 4 hours after amputation, he's kind of doesn't look too well. Let's see. So he's had good, actually, he had a good protocol, and now we're assessing him. We're trying to palpate the wound, and there's something, that part of the wound is okay, right? But there's a part of the wound that's not okay. And we're going to see what he does. Look at his coat, look at his face. He is doing, you know, turning around, trying to get down, trying to get comfortable. Doesn't like the catheter. Look at his face. Look at his breathing. So some people have looked at that video and said, you know, considering that was, you know, a huge hind limb amputation, that's not bad. Well, it might not be awful, but it definitely could be better. And so we've got a part of the wound that's really painful. We've got a facial expression that isn't, you know, normal. We've got a cat that doesn't look like, I know it's only 4 hours post-amputation, but he doesn't look like he's groomed himself. There's some other issues that seem to be annoying him, and one of them would be a catheter. Because remember, cats have that very large part of the brain, the hatred of catheter center. And so what we did was we said, okay, there's a part of that wound that needs, you know, additional. So we actually put some local anesthetic infiltration into the wound. He received another opioid, and we took out one of his catheters. So then when you see him afterwards, you'll see a completely different cat. And this is maybe only like an hour, a little bit over an hour after we intervened and took out that catheter, cleaned him up. Now what have we got? And he's had an opioid, an additional opioid. He's much more interactive. I think you can tell that his coat looks much better. He actually did some grooming. He's, you know, interested. Don't know about the tail, but he's definitely a different cat. And we are, you know, we've palpated the wound, and we're not getting that same, we're all over there. That's not a response. He's more playing with us. A very different cat. And then he's going to do a happy cat rollover, I think. And, or maybe an opioid-induced happy rollover. Okay. So I know he's upside down, but is that not a completely different face from, yeah. So, and lots of things about that video. So wasn't really difficult, some opioids and some local anesthetic on the painful part of his wound, and we have a completely different cat. This is a dog post-amputation from a completely, you know, smashed back leg, had an amputation. See what you think. And if you look at your GLASGOW pain scoring sheet in your handout, you might get some, you know, an idea. You could actually go ahead and score her if you wanted. See, she's licking her lips. She's up, she's down. Yep, head is down. Now this is, now you have to sometimes be a bit smart. Is that attention to the wound, or is that personal hygiene? And you do need to sometimes look carefully. Sometimes it's personal hygiene, so you need to look carefully. That was not personal hygiene. That was looking, licking. And if you look at the GLASGOW pain score, that's something they should not be paying a lot of attention to the wound. She was restless, head down, licking her lips, uncomfortable, and restless. So lots of things on that GLASGOW pain scale. So what do you think of her now? Almost a stretch to get up, but she's only got 3 legs now. couldn't care less about her wound, much more interested in playing, whereas before she didn't really want to interact much. Yeah. So, obviously when you look at before and after, but again, that first video, a lot of people say, that's not bad. But sometimes you say, well, we could still do better. And here's post-op spay. Position in the cage and posture. This is the day after a spay. Personal hygiene or licking the wound. It was licking the wound. Interaction, I'm not sure about you. Okay, so is she happy to see me? No. We're trying to sort of palpating the wound for... So what I got told was, one of the students actually came and said, I don't think that cat spay looks very good. The surgeon told me it was licking its wound too much and I should put a cone of shame on it. So what was the actual treatment was the cone, right? Was that the treatment that we should have? No. So I was like, no, look at her posture, look where she is. She was a friendly cat, and there's lots of things that tell us we should do something different. So we gave her an additional opioid. So she's still at the back of the cage, but not in that horrible hunched over. She was laying lateral. She is much happier. She really does want to interact with me. She's feeling much better. She wants to play. So I was like, I'm going to take your helmet off and then stand back and watch you. So I stood back and watched, and she didn't go back to licking her wound and doing all that stuff. So I hung her hat up and decided that she was going to do much better, and she did. So now that we can recognize pain and get a much better feel for it, I'm going to talk about how we take the nip out of snip. How do we actually make them look like all the good videos, and that we don't have too many of those really bad videos playing in our head, or us seeing those in our shelters or in our clinics. So there's quite a few key factors here, but what I do want to emphasize is that pain management, once you've recognized pain, is not complicated. So some of what we're going to talk about now is actually in the second part of the notes in your actual handout. But I just want you to be reassured that there are some very simple, effective strategies for keeping animals in shelters very, very comfortable. So again, just go back to the whole thing though. We are dealing with pain, and we're going to talk about pain, but don't forget about trying to alleviate fear and stress, both in the cats and in the dogs. Because obviously if an animal is stressed or fearful, that can actually contribute to pain. Or the lack of sleep in hypervigilant animals that are very fearful. Hypervigilance and lack of sleep makes you painful. It's kind of like when you're in a human ICU and you never get to sleep, it escalates and makes your pain worse. So although we're really focusing on pain, don't forget to try and focus on the other things, fear and stress, in both dogs and cats. So when you're coming up with a plan to either prevent pain because you are doing an elective procedure, or to treat pain because the animal comes in following trauma, it's really important to understand the whole pain pathway, why things get out of whack sometimes, and then where we can intervene. So very, very simplistically, what we have is every time we do surgery, we initiate a process called transduction. So we, with our scalpel blade, or it could be there's trauma, the animal gets hit by a car or something. So immediately what we do is we disrupt nerve endings there, we cause inflammation. And inflammation will cause, there's a release of all sorts of inflammatory mediators, and those mediators sensitize the nerve endings. And then what happens is that information from the site of trauma or surgery is going to be transmitted through the central nervous system to the spinal cord, and it arrives in a very specific part, into the dorsal horn of the spinal cord, where it is processed. And then when the animal is conscious, that becomes pain. Now remember, an animal under general anesthesia, by definition, cannot experience pain. Pain can only be experienced in the conscious state. But this is happening during surgery under general anesthesia, and we want to do something about it before they wake up and have that conscious sensation of pain. So there is some inbuilt modulating pathways. So animals do have endogenous opioids and so on, and there actually is a cannabinoid system which responds to cannabis, which they actually have. And all these things will help modulate pain. But what we're going to try and do is alter transduction, alter transmission, and build on modulating those incoming pain signals. Now, what happens is if an animal is traumatized or has surgery without any benefit of analgesia, what happens is you have all of this transduction, which, of course, after the procedure's over, that surgical site is painful. That's what we call primary or peripheral sensitization, and we would expect that. And so we've got that process of transduction. But what happens is this becomes exaggerated, and we get more and more and more input and more transmission, more pain signals are now going to the central nervous system, and they bombard the central nervous system. And we used to think that once an animal was a few weeks of age and older, the central nervous system could not be altered. That is not true. The central nervous system is much more plastic than we think it is. And if you look at research animals that have experienced pain and look at their central nervous system, it is different. It gets rewired and altered by the bombardment with pain signals. So that is what happens, and that is what you've probably all heard of as central or secondary sensitization, or some of you, and that's why I've put this pictorial here, the animal becomes rewired. So now the actual processing of any future pain signals is altered. And because this is happening in the central nervous system, it's not just the surgical site that has altered pain sensation. When you go to touch an animal that has been painful for several days, it's not just the surgical site that's painful. The animal seems hypersensitive everywhere because you've altered its spinal cord. So this is what we want to prevent. We want to prevent this happening. And so we can intervene in many, many different places. This is what I'm saying. The actual preventing or treating pain, that's the easy part. You just have to know how to do it and then recognize the painful animals. So obviously, if inflammation is what starts it all off, then non-steroidals are going to be excellent pain management tools. They work at the site of inflammation, but actually non-steroidals have a very important role to play in the central nervous system as well. We could block the pain signal getting from here to the spinal cord with local anesthetics. We can enhance the modulating systems by giving the animal exogenous opioids. And obviously, they work in the central nervous system, spinal cord, and in the brain. So we have lots of places that we can intervene. I think one of the very important key factors to understanding how long we need to treat is understanding how important inflammation is and how it drives pain. So often, people say, how long do I need to treat? Well, of course, the flip answer would be as long as they hurt, and then you can stop giving your analgesic, but we're not that good at assessing pain. So we need to kind of understand how long we can predict that pain might last. So what we have to understand is post-operatively or post-trauma, just because the surgical procedure is over, the stimuli aren't over. The inflammation or the inflammatory injury continues. And that is what generates the nociceptive stimuli and this input and bombardment of the central nervous system. And depending on how much inflammation there is, it could last for as little as a few hours after, say, a very minor incision, or several days, or even several weeks, depending on how much inflammation and trauma there is. So this diagram, I've tried to to explain the why some pain protocols fail. So I'm going to go over this in a little bit of detail, because I think a lot of people suddenly go, I know now why. I gave my good pain management for the first day and then stopped, and the dog didn't look very good on the second day. So if we look at the very top here, and the time is arbitrary, but we could say it's several days. And what I've tried to pictorially show you is acute inflammation, which is quite significant at the start, right after surgery or trauma. And then if we do nothing, over time, inflammation resolves and goes away. But during the acute inflammation and this phase, which we call the time where we can reinitiate pain, can be significant. So the animal's painful here, and eventually the animal becomes more comfortable and pain disappears as inflammation disappears and abates. So what a lot of people do is they have an elective procedure, they give analgesics for a very short period of time, and so the animal feels very good here during the very acute inflammatory phase. You withdraw your pain management protocol, but there's still enough inflammation present in the wound that you can have complete reinitiation of the entire pain pathway, resensitization of the nerve endings, and so on. So the animal feels better here, but then is painful, just as in this one, from here until finally the inflammation resolves. So what we're really trying to do is provide our protocol, our pain management protocol, to go all the way through to this resolution phase where when we withdraw our pain management, nothing reinitiates and the animal, you take it off its pain meds and it's comfortable and nothing reinitiates. Now, how long this line is going to be totally dependent on how much inflammation there is. So in a more pictorial sense, I would like to show you, so obviously here, you would all look at that wound and say, oh, definitely needs treatment because we've got a lot of inflammation. Some of you might think this looks pretty good and you might withdraw your treatment, but this is when everything reinitiates and you're back to square one. You cannot withdraw your treatment until you're in a phase where there's complete resolution and inflammation is almost negligible. Now, how long inflammation lasts after surgical procedures is not a thing that we understand completely, but it's obvious that the inflammation from this wound is not going to be as much as from a wound like that. That's kind of intuitive and makes sense, correct? But just to show you that inflammation is what drives pain, this is a study from humans, but the exact same study has been duplicated in the dog. This is looking at laparoscopy, so very, very little incisions, minor inflammation, minor trauma, versus laparotomy, big incision. And then what they did was they looked at an inflammatory mediator, which is easy to measure in blood, and obviously big incision, lots of inflammatory mediators, little incision, not much. And what they found was these were the people reporting their pain. The pain score completely mirrors the inflammatory response. So inflammation is what's important. So what, in a nutshell, does that all mean? What it really means is, yes, those small incisions really matter. So the smaller your incision, the more important it is. For a small incision is going to cause a lot less pain. Surgeons tell me that wounds heal from side to side, and I'm saying, well, pain goes from end to end. So once you kind of get those key concepts, I think the rest kind of all falls into place and is actually fairly easy. So we have opioids, non-steroidals, local anesthetics, ketamine, and a little bit about the alpha-2s, which I'll talk about in the next talk. But you know the pain pathway now, and you know now where these all work. So pain management, questions preemptive. Do I have to use lots of different drugs? Can I use long-acting drugs? Are there protocols without controlled drugs? And certainly I go to places where we cannot take controlled drugs, and I have to figure that out. And then some of the feral cat procedures. So opioids do tend to be the backbone of all acute pain management protocols. They're very, very, very effective, can be very inexpensive, but I know obviously you have to keep records. But there is very strong evidence that if you're going to use opioids, they need to be used preemptively. So preoperative administration has very positive benefits. It prevents central sensitization, and it actually, put it more simply, it requires a lower dose of an opioid to prevent pain than it does to treat pain once pain has occurred. So just to show you, this is like, good scientific, background for us, knowing that we need to get our opioids on ahead of time. So this is meperidine, very, very short-acting opioid given to animals before spay, post-operatively, or some animals didn't get it at all. But we know that analgesic, that opioid, probably only lasts an hour, hour and a half. But by giving it pre-operatively, even out as far as 8 hours, 12 hours, and 20 hours, the dogs that get it pre-operatively have an obvious benefit to that drug because it prevented central sensitization. Other advantages of using opioids prior to induction are it reduces your anesthetic requirements for your induction agent and your maintenance agent. So they're less propofol, if that's what you're using, less isoflurane. You get fewer cardiovascular responses to surgery. You have better maintained blood pressure because you're using less induction and maintenance agent, and you actually end up with less respiratory depression. Although some people think that's counterintuitive because we're talking about opioids. But because you use less of the induction and maintenance agents, that is true. Does the route of administration matter? Absolutely yes. And we have done very good studies in cats, and they've been done in dogs as well. The one inefficient, almost like very poor, subcutaneous administration of opioids is the worst or least effective method of giving opioids to dogs. You get slow onset, you get more nausea, you get more vomiting, you have less intense effect. So try, if you have an IV catheter, use that. And if not, IM is your second best choice. Sub-Q, extremely ineffective route of administration. And people think if you give it sub-Q, it lasts longer. We have disproved that. That is not true. Sustained release buprenorphine is something I'm getting a lot of questions about, and actually Dr. Levi was asking me about it. And it is something that can be bought from Zoo Farm, sell it. There's not a lot of good data, but there is a nice paper came out of Colorado State just recently using it in a feline OHE model. They gave one single dose of this sub-Q, and then they compared it to giving the oral transmucosal buprenorphine, just dropping it in the cat's mouths. And both protocols were equal. There was no difference between treatments. All the cats did quite well. So certainly these sustained release formulations are attractive for feral cats. The only thing I would alert you to is I'm getting quite a lot of phone calls, and if you look at the Colorado paper, injection site reactions are being reported with this. And we, obviously an injection site reaction in a cat is a little bit worrisome. Non-steroidals for dogs, definitely if inflammation is what drives pain, we should be using non-steroidals. In dogs, it's easy, right? You've got tons to choose from. So that's easy. In the cat, not so easy. But just to point out that we have 2 licensed non-steroidals for cats in the United States right now. We have meloxicam injection. It's a single use only, sub-Q for surgical pain. And we now have robenacoxib, which is, its trade name is Onsior. So when I say we have it, it is approved by the FDA. It was approved this March for use in cats in the United States. It's got a 3-day label for orthopedic surgery, ovarian hysterectomy, and castration. You can find out a lot about this drug at the FDA website. It's going to be oral only in the United States. It's an oral tablet. The Feline Advisory Bureau gave it an award for palatability and easy to give. So we're not sure when we're going to get it, but it should be early next year. And it'll allow you on label to treat cats with a non-steroidal for 3 days. Local anesthesia, I think, underutilized, and can be very, very effective. These are just images of us down in the Yucatan doing a spay and neuter clinic, obviously on picnic tables here. So we were doing local line blocks in the dogs, in the female dogs, and we were doing injections in the male dogs as well prior to surgery. So local anesthetics, there is good data to say that they do help. In this feline spay study that was published back in 2008, infiltrating the skin, mesovarium, and the muscle layers, they were able to give fewer top-ups, have to alter the level of anesthesia less. They had lower heart rates, less respiratory depression. So local anesthetics beneficial in cats. And here is just if you go to this website, the VASG website, you can learn how to do an intratesticular block in a male cat. And that's what we did when we were down in Mexico as well. Intraperitoneal local anesthesia for canine spay has been well documented that it's very beneficial. There was a publication came out of Michigan State University a long time ago now, 2003. All the dogs received butorphanol, and then they either got lidocaine intraperitoneal, bupivacaine intraperitoneally, or saline intraperitoneally. And then if they got lidocaine in the peritoneum, they also got a splash block of lidocaine in their incision at closure. So what was the results of that? What they found was bupivacaine in the peritoneum and on the wound. These dogs had lower pain scores and required less rescue analgesia. And then these are just the exact doses and protocol that they used, and then the wound infiltrated. So inexpensive and easy to do, and it's not a controlled substance. What about ketamine? Ketamine is known to prevent central sensitization, but when you use it as part of your anesthetic protocol, is it of any benefit? Well, the answer is yes, it is. Certainly for dogs, we know that. This was a study done in the United Kingdom where the dogs had no other analgesic. None of these are analgesics, but they got ketamine. They either got saline at induction and extubation, ketamine at induction followed by saline, or saline at induction and ketamine as they woke up, and that was the dose they got. So what did ketamine do for spay pain? Well, what they actually showed was that when they were assessing pain, good evaluators, look at this, big difference between the pain score in the dogs that got ketamine prior to their spay incision. And no other analgesics on board, and it made a difference. What else did ketamine do? They looked at wound sensitivity, and it made a huge difference. The animals that received ketamine, and it didn't really matter so much whether it was before or after the spay, but as long as they got it, it took a lot more pressure on their wound to elicit a response compared to the dogs that got no ketamine. So using ketamine as part of your protocol is a beneficial thing to do. And then to finish up on multimodal, do I have to give lots more than one drug? Well, intuitively it makes sense, but there actually aren't very many good studies. But there are a couple of studies combining non-steroidals and opioids that show that that's a good combination. One of them is in cats, and they looked at combining buprenorphine and carprofen. This was done in the UK, where both of those are licensed for use in cats, single treatment only. Now, what they found was there was no difference in how sedate the cats were, so that probably wasn't a factor that altered how they were able to score the cats. But what they found was if you combined an opioid and a non-steroidal, this is the purple line here, much superior. The opioid alone, very good up until when you'd expect it to wear off. And then the non-steroidal alone, good overall, long-term, but not as good as the combination. So it is a good combination. And then this is a study that was done here at University of Florida, actually with in conjunction with our shelter group. And we looked again at buprenorphine and carprofen, and we found it was very beneficial combination. We found that if you include your buprenorphine ahead of the surgery, you need a lot less propofol to induce them. Those dogs, because they had less propofol and probably less inhalant, better blood pressure. The combination, we got longer lasting analgesia, and we actually measured the spay incisions and photographed them. And if you include the non-steroidal, we had less, and we could document less wound swelling as well. Remote area spay and neuter initiative, something that everybody involved in shelter medicine is probably going to volunteer to do. And I've been going down to the Yucatan and doing dog and cat neuters and so on, a lot very educational thing for the kids down there and for our students. And often we go down there and we can't use controlled drugs. We just can't either buy them, and we, God forbid, trying to take controlled drugs through a Mexican airport. So I decided I wasn't going to try it. So I started looking around for some protocols that I thought I could use that wouldn't involve a controlled anesthetic, and I came across this paper, and they looked at using propofol or ketamine following medetomidine. And what they found was that an alpha-2 followed by propofol is very, very effective for doing routine procedures in dogs, and this is what we did. We sedated our dogs. Well, now if we go, it'll be dexmedetomidine. We did our local block, and then we used IV propofol as needed. And here's Dr. Azaza working on one of our dogs down there. These dogs woke up very, very nicely. They had to usually walk home. They didn't, get picked up and taken home. They had to walk home after their procedure. And then just finally, whether or not I can tell you that we have great updates on analgesia for our feral cat population. We've been doing and trying to develop better techniques for the feral cats, trying to get faster recoveries and hopefully better analgesia. It's very difficult, as you can understand from what we've talked about, to assess pain in some of these feral cats. I would say that predominantly this is still our backbone, the TKX. This paper is available now online. It's just being published. And we had faster recoveries with this newer protocol, but we did have a lot of animals that were having very, very low saturations on the pulse oximeter, and whether or not that's a long-term issue or not. But certainly we're developing or trying to do better with the feral cat protocols. Certainly it's something we're quite motivated to improve on. So hopefully that just reassures you that once you can recognize pain, the treating it and preventing it part is pretty easy, and it's not as complicated as some people would try and make out nowadays. So thank you.